live.
Hello.
Good morning,
Hi.
everyone. This is Dr. Abram with Quentin, our fellow, and Dr. Tanguy to my right.
Yes.
So we have today a case of a gentleman that's a surgical turndown of a calcified left main ostial circumflex lesion. Next slide. So this is a 83-year-old gentleman. He presented at our institute 2 weeks ago with typical chest pain and elevated troponin. The ST segment were normal, so our diagnosis was end-STEMI of type 1. His known risk factors are hypertension, cholesterol, and diabetes. Also, we know from medical history that the patient had multiple falls in the past. He's a frail patient. He also has chronic kidney disease with creatinine around 120. During hospitalization, he underwent a nuclear stress test. We demonstrated severe ischemia in the anterior and lateral wall with an ejection fraction that was slightly reduced, 30 to 35. A TT, however, demonstrated that the LVEF was 43%, and the patient had anterolateral and posterior wall akinesis. The hospitalization was lengthy, was complicated by pneumonia, but finally the patient underwent cath. Next slide. Next slide. So the RCA was good caliber. There was some mild CAD in the mid portion, dominant RCA, but nothing of interest here for our interventional cardiology service. Next slide. The left coronary demonstrated multiple lesions. It's a bit hard to appreciate, but in the 1040 or the AP cranial view that you can see on the left of this PowerPoint, there was a moderate to severe lesion of the LAD. Also, you can see in the spider view on the right side of the screen that there seems to be a severely calcified lesion of the ostial circumflex and also of the mid circumflex. Next slide. Yeah. So at this point, we also completed the angiogram. You can actually see that in the REO caudal view that there is a severe lesion of the LAD and also a severe lesion of the circumflex that you can appreciate in this view. Next slide. So at that point, we confirmed that there was a severely calcified ostial circumflex lesion and a severe lesion of the left anterior descending artery. Because stenting the ostial circumflex will involve stenting the left main, and also because the patient has LV dysfunction with 2-vessel disease in a diabetic patient, we opted for a heart team discussion. Next slide. The patient had preference for coronary artery bypass graft, and he was actually scheduled to undergo the operation. However, during the hospitalization, he had an accidental fall, and while he was on IV heparin, he developed iliopsoas retroperitoneal bleed that was complicated with hypovolemic shock and also required transfusions. He also had severe pain in the right leg where the bleed occurred that required physiotherapy, but the patient mobility never recovered fully. And because we want patients to be as mobile as possible after cardiac surgery, we felt that the patient was too frail and geriatric, basically, for coronary artery bypass graft. So after heart team discussion, we opted for PCI. Next slide. So initially, our plan was to do PCI of the LAD and the circumflex. Next slide. And you can see here, maybe next slide again. You can see here that we actually stented the mid LAD, but the patient was in severe pain in his lower back, and we were never able to finish the angioplasty. That was last week. So we're just able to stent the mid LAD. So now the patient remains with a severely calcified circumflex lesion, severe ischemia, and LV dysfunction. Next slide. So after the fact, our plan was to wait for the improvement in the hematoma and also repeat the PCI of the left main and circumflex, which we will do today. Next slide. So maybe I'll let Dr. Tanguy talk about the considerations of this case.
Thank you, Robert, while you do the IVIS at this time. So it's kind of that consideration of a frail patient that was recused by surgery, could not complete the full revascularization in one setting because he had terrible pain from his hematoma. So now the consideration, should we go radial or femoral? At some point, because of the access, we said, let's go radial today. So with the 6 French, we use the EBU.
Yeah, we are on XB35.
Yes, and then
OK, on va prendre un autre IVUS, s'il vous plaît. Une autre marque, OK? Ça marche pas.
L'IVUS marche pas?
Refinity, s'il vous plaît.
So we're having some technical
en fait,
issues.
le Opticross.
Okay, we have some issues with the IVUS, so we'll redo. So
N'hésitez pas, mais ça dit erreur matérielle, on a changé de capitaine.
Radial approach, we did not think because the patient was stable and we had revascularized the LAD to use a mechanical support. Next slide. Now we would like to complete the revascularization. There's the left main, you saw, I think, distal left main, as well as the circumflex that has 2 stenosis. And at some point, Dr. Avram will tell you how we wired that because it was technically challenging. Had to use a supercross, but we'll discuss that in a few minutes. So I think the discussion was to do provisional stenting. So use a stent, the left main and the circumflex, open the struts for the LAD access, but not a 2-stent strategy at this time because there's no disease at the ostium of the LAD. You can appreciate on the angiogram. Next slide. Now, obviously, there's some discussion here we can have either between the us or with the audience on Slido. But it's again the strategy of calcium modification. Orbital atherectomy was our first choice, but intravascular lithotripsy could be an option. Rotational atherectomy at the same time, it's an unprotected left main, so we think orbital will allow us to do the superficial calcium and deep calcium, but we would like to have the IVUS pre.
Yeah, so in this case, you can actually see on the angiogram that there is the calcium in the mid circumflex in some of the views looks like a calcium nodule, but the left main to circumflex looks like a long lesion that's severely calcified. And those lesions were studied in the Orbita and Eclipse trials that studied orbital atherectomy. So they were part of the inclusion criteria. Also, the distal left main is a very big vessel. We think it's at least 3-5 millimeters. So rotational atherectomy is not well suited for very large vessels. So I think in this case, really the 2 options is either IVL or orbital atherectomy. And we will prefer orbital atherectomy if we don't have eccentric calcium, if we have circumferential 270 degrees or very long lesions, at least 15 millimeters of calcified plaque. Next slide.
Yeah, next slide.
So in this case, this is a higher risk patient because he's a surgical turn down. And we know those patients have more adverse outcomes and are actually at very, very high risk. Next slide. So left main disease deemed surgically ineligible are very high risk patients. You can see here over 20% MACE in hospital. And this is much higher. It's odd ratio of 3 or 4 compared to patients who are not turned down for surgery. Next slide. I wanted to talk about the Renovate complex PCI study because this patient fits the inclusion criteria. So this is a study that was recently published in New England Journal of Medicine that included patients with complex coronary artery lesions. And those patients either had true bifurcation, a CTO, severely calcified lesion, or unprotected left main. And they randomized patients to either intravascular imaging use during PCI or angiographic-based PCI. Next slide. The procedural success was defined as a residual stenosis diameter less than 10% angiographically and a minimum stent area of more than 80% of the mean reference lumen area of the vessel. So on IVUS, that was 5.5 square millimeter on the basis of IVUS, and OCT was greater than 4.5 millimeters. In left main coronary artery, it's actually a larger vessel. So the minimum stent area had to be greater than 7 for the distal left main, as is this case, or greater than 8 millimeters square in the proximal left main. Next slide. So you can see here that patients at 3 years had 22% target vessel, 12% target vessel failure, and patients in the imaging guided PCI had 7.7%, so almost a half of the event rate that in the angiographic guided PCI. Next slide. And next slide. Click 2 times, sorry. Okay, that's it. So you can see actually patients that had distal left main and were refused for cardiac surgery actually had the most favorable outcomes in this study. And also had calcified vessels. So our patient actually fits the definition of the Renovate Complex PCI study. And based on this forest plot, this is a patient that would benefit the most from intravascular guided intravascular guided PCI. Next slide. So our plan for today's procedure is to use intravascular imaging to guide the approach, and based on the extent of the calcium, the localization, and the distribution of the calcium, we will either choose orbital atherectomy, which will be my first choice, or IVL. Maybe we can show the angiogram now. We can close my slides and show the angiogram that we performed today. Great, play. Montre le 15-25 au début et le wiring. So this is the angiogram today, and we had a run-through wire. We're actually in a 7 French radial access. We're using a 7 French EBU 3.5. And already you can see that the circumflex is almost at 90 degrees. And then there is a calcium nodule right at the bifurcation with the first marginal. Next slide. Next angiogram. Yeah, show it. Okay. So my wire was actually committed and was always going in the marginal, despite trying different bends and approaches. It was not able to go in the circumflex. This is partially explained by the nodule at the bifurcation, which pushes my wire away, and also the wire bias, which pushes me in the opposite wall of the vessel. So next slide, actually show the wiring with the microcatheter.
Next. Yeah, next. That's good.
So this is a supercross angle microcatheter, 90 degrees. Show the previous. Show with the microcatheter, please.
Yeah, before the UP4. Wait, this one.
Okay, we were able to wire the circumflex using the supercross, which is angled microcatheter. Which basically allowed us to push the wire towards the circumflex away from the marginal. And I think use of, such microcatheters can make the wiring of difficult lesions like this osteocircumflex or this mid-circumflex much easier and approachable.
This was very elegant, Robert. As you perform the IVUS now, we tried to do the IVUS, but the lesion was so severe that the IVUS would not cross.
Yeah, show the dilatation, please.
Yeah, can you show the dilatation? The next slide.
And retourne l'écran vers nous, s'il te plaît.
Dilatation.
Norelis, retourne l'écran vers nous.
Okay, so that's the wire, the supercross. Okay, next one. Okay, to prepare IVUS. So let's prepare the IVUS, and then we'll edit this case because now I want to show the balloon because we
had some technical issues with the IVUS. So our initial IVUS didn't work. We had a hardware failure. First time I get this error, but when you're live, you have to expect everything.
Yeah.
And we're prepared. We have a different IVUS manufacturer here, so hopefully this one works. And we have the IVUS in place, so we had to predilate the lesion because the IVUS would not go past that secondary bend in the marginal. So it would go past the left main to the circumflex, but it would not be able to go in the mid-circumflex. And after predilation with a 2520 non-compliant balloon, we actually were able to push the IVUS further ahead.
So we're just waiting for the machine to run up so we can kind of show you the IVUS. And then our strategy will be depending on how much calcium we see and the length and the circumference to decide which type of ablation therapy we're going to do. The patient is now quite stable.
And not in pain. Like, keep in mind, last week, the patient was not able to tolerate more than 5 minutes of the angioplasty. He had severe back pain which basically pushed the procedure to today, but probably his hematoma has improved a lot.
Yeah,
I would
almost
assume.
considered anesthesia here, but we're doing mild sedation. I think now he's stable.
Yeah, very stable.
Well, that's something very few times a year we have to consider sedation.
Is the IVUS working?
Who cannot support being lying down to do the procedure in a more quiet atmosphere. But now you cannot hear him. He's asleep. We want to see him. He's doing well. The saturation is okay. The blood pressure is okay. So at this time, we're just waiting for the IVUS machine to be set up. The catheter is there. One heparin. And
I gave an extra 3,000.
Yeah, good.
Of heparin.
Monitoring the ACT. And we have some question from the Slido. Why are you considering the rotational ablation?
Yeah, so I think rotational ablation in this case, there's two issues. First of all, there is distal left main is a big vessel. I think it's a 3.5 or 4.0, and we know with orbital atherectomy at low speeds, you can actually touch the edge of the vessel in very large vessels. The second one is the angle. So in this case, there's a 90-degree angle, and there's another 90-degree angle into the distal, mid to distal circumflex. And I do think the risk of perforation is higher with IVUS in this case. So those are my two options, but we'll see. You know, we could always reassess.
Yeah,
I'm actually going to reset and restart because I think I moved it.
We'll do the IVUS because that's the focus. What we've been waiting. We'll answer a few questions. There was a question about the femoral versus the radial approach. In this case,
retroperitoneal bleeds, spontaneous. So
at some point,
live view that
more comfort by the radial, and we have enough support now with our guiding or wire. But this is true that you have to consider that if you had not had a story of a psoas hematoma, retroperitoneal bleed, maybe would have gone femoral. But so our main access is radial, less local bleeding. The hematoma he had was not from the access, was actually from falling. He's a frail patient, and whatever he fell as walking on the ward. Now, there was also a question about DAPT. That's a good question because of the recent hematoma. He's been stable. The hematoma has been better. The hemoglobin stable. So now I think he's on aspirin clopidogrel.
Yes, he is. Yeah.
So I think it's more secure in a frail patient to have clopidogrel. We can see, and I think you can appreciate the IVUS.
Can you see the IVUS?
Well, can you see the IVUS? I'm not sure. Let's see. Can we see the screen, the IVUS? We can see superficial calcium and also deep calcium. And here you see quite a large amount of calcium. That's in the left main now.
Yeah, it's the distal left main to osteocirc.
You see that it's a wide, large left main.
1, 2, 3, 4.
We can discuss
that. So it's a 5.0 millimeter left main. And I've seen two things. I think we're going to stop the IVUS and we're going to review it and replay it for everyone to see. But first of all, in the mid circumflex, there is a calcium nodule. This is eccentric calcium. It seems to be less than 180 degrees. So my approach for that lesion would be to treat it with shockwave, probably the mid circumflex. However, when we look at the osteocircumflex, we see that the calcium is greater than 270 degrees, and it is a long lesion like expected. So you can see here, that's the mid circumflex, and you can see the marginal branch coming in at 6 o'clock, and you can see the calcium nodule at 6 p.m. going now to 9 p.m. And now it becomes a bit more calcified on about one quadrant. It's a very big circumflex. So you can see here, it's at least 3.5, if not 4, and that's the osteocircumflex. And you can see that there is calcium at least 180 degrees, and some areas 270 degrees. And this is the left main. And the left main, again, is very, very large. We're talking a 5.0. Here, there is some calcification, but non-severe. And then we head towards the guiding catheter.
So that would change your practice. With the IVUS, you would change your approach.
So I think, at least for the mid portion, I would maybe attempt shockwave just because of the eccentric calcium.
Yes.
But for the proximal portion, I think orbital atherectomy is the way to go. So how about we start with, can we go again in the mid circumflex? Où est-ce qu'on voit le nodule? Après la marginale. Ouais, so this is 3.0 vessel. Okay, so we'll take a 3015 or 30 shockwave balloon.
Okay, trio.
So I think I would get rid of that because after that it's going to be harder.
Hopefully it's going to go.
Hopefully it's going to go. And then I would exchange the run through for a Viper wire, and we'll do orbital atherectomy in the ostium. And then we'll probably stent with a 3.0 or 3.5 stent. Maybe we'll use 2 stents, I think, because we don't have 3.0 megatrons. So I think we'll go. Yeah, it's a 3.5. Maybe we can. We'll see. We'll see the measurement. Maybe we can stent both lesions with one long megatron that would go all the way from the left main to the circumflex. Then our plan is to open the struts towards the LED, but the LED is not disease. And it also seems pretty easy to wire. So we're not using a second wire in this case because of our approach with orbital atherectomy.
Yes.
And we'll open the struts after once the stent is deployed, and then do a pot with a 5.0 balloon. And then hopefully with the final IVUS, we get a satisfactory result.
I agree with you, Robert. The Megatron, I mean, obviously we have to have the right size, the right length for the circumflex and the left main, but it offers you more strength. And also you can go up to 6 millimeter in the left main. So we have the strength of the stent, the size, and then we open
prépare le shockwave, puis après ça, mesure-moi le vaisseau d'ici jusqu'au guiding.
So when you can open the lumen for the LED, we can go up to 5 millimeters. So it should allow us to have a great result that we will check after with IVUS to optimize, again, the result, make sure we have full position. So at the same time, it's a mixed combination now of lithotripsy and the circumflex.
I think so. So we know that orbital atherectomy is not good for very eccentric calcium or short calcium lesions. Orbital atherectomy is very good when you want to polish the vessel to sand basically calcium off of the edge of the vessel that's not eccentric, that's ideally long. It tends to improve the vessel compliance, and it's also potentially safer than rotablation in this case because of the tortuosity. Although severe tortuosity is a contraindication also for orbital atherectomy.
Okay.
And I'm interested to see what the audience think. Would they use a different calcium modification technique in the mid circumflex or the proximal circumflex, and why?
Yeah, there's different approaches, but I think yours is logical based on the IVUS. Obviously, we do need at some point more data, but I think the data is interesting, promising with the that's the lithotripsy, the shockwave. As we prepare with the shockwave, I can see that maybe the question on Slido, and we can address some of them. Or if you have comments and your own approach, that would be interesting too. Yeah, go there. Oui, il faut préparer l'orbital. Ouais, s'il vous plaît.
On va sortir aussi le Corsair XS. Et
there may be plaque shifting in the LED.
Corsair et le...
So the question is good about placing a wire. There's a question. There may be plaque shifting into the LED. Did you consider placing a wire? Absolutely. We discussed that just before the case. And because the LED is not diseased at this time, and we plan to do orbital atherectomy, we do not want to leave a wire in the LED. But I said, let's prepare a wire in case we have that plaque shift. And after the orbital atherectomy, we can wire it before stenting. But at this time, we hope that there will not be that much plaque shift using the orbital atherectomy in the left main and the ostial circ. The intravascular lithotripsy will be done in the mid circumflex, where you saw by IVUS the calcified nodule. So the Teravam is positioning the catheter. Maybe there's another question I can answer while Robert is getting the
enabled therapy.
Yeah, so Josephson, thank you. He would use rotational and IVL, so supporting what we're doing. So thank you, very encouraging. Again, there's always that unknown how the vessel will react, how the nodule will react. Sometimes it's not so easy to really break, and you will attack the other side of the vessel. But at the same time, with lithotripsy, I think we have a chance of breaking, changing the plaque modification, the calcification. Other question? Yeah, while we... who makes the Megatron? Megatron is made by Boston Scientific. It's approved in Canada. And again, we've been using it for large vessel, ostial lesion of left main of RCA, calcified, and he has a more strength than the regular thin strut DS.
So you can see that
undersized.
we had some issues delivering the shockwave balloon, but we're well supported with our 7 French EBU. And now the balloon was delivered. We actually don't see very well the calcium in this view, but maybe if we go in spider.
Yeah, open a spider.
Maybe if we go in spider, we can better appreciate it, because here the balloon looks well expanded and it looks like there's no lesion. However, we clearly saw in the IVUS that there is a calcium nodule at that point. So it's very eccentric. It only occupies one quadrant. So it's possible in certain views that are orthogonal to the calcium that we don't actually see any lesion. The check mark, s'il te plaît. Check mark. Check mark. Garde appuyé sur le check mark. OK, déplace la table pour centrer le rouge.
And that's
Okay, so we're using the roadmap
of the Philip room with the roadmap,
yeah,
which is quite interesting sometimes to help us. Okay.
Centre-moi un petit peu mieux sur le ballon. Centrez-moi un petit peu mieux sur le ballon.
Okay.
Okay. I think it looks
That looks
good.
pretty
Actually.
good there, huh?
Okay, let's remove the balloon and let's exchange for the Viper wire.
To prepare for.
Do we have a Corsair?
You have the Corsair. So we don't need it anymore.
I don't think so.
C'est contaminé. On enlève ça. Ben, il a touché là-bas, là. On va l'enlever.
On va revenir en AP20 vers les pieds.
Qu'est-ce que tu veux?
AP20 vers les pieds.
AP20? Je peux te le faire. Là.
Ah, merci. Ça m'amène exactement au micro-cathéter pour échanger.
Et puis après, on prend le Viper
wire.
floppy. Et puis
tu as le micro-cathéter?
Il arrive.
So our plan now is to exchange. So I'll just do a CNET to make sure there's no complication.
Okay, c'est le Corsair.
So we still see the calcium nodule, but the balloon was well expanded at that point. So
yeah, the flow is good. And
you still see the calcium in this area.
There's nothing in the LED.
Going to get the Corsair and a trapping balloon, and we'll exchange. We'll shuttle in the Viper wire. Je vais prendre le trapping balloon. 2.5.
Un trapping balloon.
Trapping balloon. Trapping balloon. Trapping balloon pour trapper son chat. C'est le 3-0.
Well, actually, you know, I think we can advance the microcatheter without trapping. The vessel, the wire is distant, it's not moving.
Okay.
Okay, we have the wire.
Pas besoin du trapping.
Pas besoin de trapping.
Pas besoin, hein? C'est ça, je pensais bien.
Okay, we're gonna remove the wire. Have the Corsair in place. Sometimes it's safe. If we use the run through here a lot, and depending where the wire is parked, we don't get. We're not going to get perforations. So we don't necessarily need trapping. Je vais juste faire une petite courbure sur le Viper wire.
Je vais te laisser faire à ton goût, là.
Aiguille.
Veux-tu une aiguille ou tu vas rentrer directement, hein?
Always put a little tip distally just so we don't exit the vessel. So put a little J-tip.
A small tip, yeah, a small curve.
Very small tip. You see the Viper wire is right here.
Okay.
I'm using the roadmap just to guide it. Hopefully it's going to go in that main branch. Going in this little branch.
Like the,
that's it.
That's good there. Huh?
Okay, I'm going to keep the wire in that place. On va rentrer fluoro.
Are you okay?
Yeah. Just removing the microcatheter. Oh, fluoro. Tu l'as?
Non. Bon.
Okay, we got it now. So exactly what suggested was to use a 125. So you go with this.
What was suggested, Jeff?
1.25 to start.
So we say there may also be plaque shift. Did you answer that? Yeah, there might be plaque shift. So the problem with the orbital at that point is that we have to keep only one wire in position with our approach. However, I think both the LED and the marginal branch are almost straight, like for wiring. And I do feel confident in recovering and saving those branches if there is plaque shift after the orbital atherectomy. We say, is Viper a good foundation too for IVL?
Yeah.
Yeah. Did you answer that question?
I don't know. I mean, I didn't see the question.
So I'm not sure what you mean. But the Viper wire is only to be used with orbital atherectomy.
It's a long wire.
It's a 300. It's like the Rhoda wire, so you cannot use it for other purposes. You cannot put the IVL balloon over it. It's meant only to be used with.
I think so.
I
don't have it yet.
So for those that are less familiar with orbital atherectomy, it's basically a eccentric axis where the burr turns and it polishes the vessel. There's two speeds available, the 80K RPM and 120K RPM. The 80K is safer for perforation and good flow. Normally we would put a pacemaker if we did it in the right coronary artery. But in this case, it's a non-dominant circumflex, so there's no indication for pacemaker. We need to test the system before we go in the patient. Do you have the wire?
No, we don't have the wire yet.
Yeah.
Okay, now we got it.
Okay, good. So to test the system, we basically engage the brake down and then push. And we make sure that it's moving and that we have the drip going. I don't know if you can see.
Close up on the camera maybe to see the hand, the left hand near the left.
Yeah, maybe we'll rotate the camera towards me, towards my left, the other way.
No, the other way. Exactly. To the hand, close to the hand. Maybe you can see it now.
Maybe move it. Okay. Good. So we cannot go like too long. So it's ideally 15 seconds. And also positive to the rotablator. Here we really want to go 1-to-1 with the vessel. And we also want to polish the vessel. So we do very gentle movements, maybe 1 millimeter per second of polishing, whereas the rotablator is more like pecking motion, where we would poke at the plaque. Okay, let's go.
Yeah.
So remove the brake. So we can either advance as a 2-man or 1-man technique. Here I'm advancing slowly while the fellow is removing the wire slowly. We try to go 1-to-1. So I'm advancing 5 millimeters, he's removing 5 millimeters, and we coordinate with fluoroscopy.
Again, it could be one person.
Once we, yeah.
Now we're 3% because of the live case, but at the same time, as you use more and more, you get used to the technique, and you can do that one operator.
Yeah. Here we are going to listen for tonal changes to make sure that the vessel is properly polished by the orbital atherectomy.
Et attends, tu remets le guide pour pas qu'on le casse, dans sa force, s'il te plaît.
Je peux le remettre, ouais. Mettez le guide dans son terceau.
Yeah.
So we like to put the wire back in the circular plastic holder that it came up with, just because otherwise it's a long wire and it's going to fall, it's going to get contaminated. This is just good practice.
Yeah.
Parler du Dynaglide.
Yes, and also there is a blue button. It's a bit hard to see. I'm not going to But there's a blue button right at the edge where if you hold it for 3 seconds, it's equivalent to like the Dynaglide on Rotablator. And it might be easier to help you advance the Diamondback 360 close to the lesion if there's tortuosity. So I'm not sure if it's going to go here. We had issues with the shockwave balloon and the IVUS initially, but hopefully it's going to go. We'll see.
Excellent. Let's go. Nice image. Thank you to the camera. So we're getting there.
Avance le Diamondback. Avance plus. Okay. So you can see the Diamondback is there. Now let's see if it's going to go, down. Just a second. Okay. So I think this is good. So we have to engage the brake. So we push the green thumb thing down, and then I release a bit the pressure. Okay, and then I'm going to start it. I'm going to listen for tonal changes. Do I see the console somewhere?
The console is there, yeah.
Okay, good. Perfect. So you listen to the tonal changes. And you want to go very slowly, polish the vessel.
Yeah.
Compared to the Rhoda where you do pecking movement. So you hear that the sound is not the same. So it's polishing the vessel in the mid portion and in the proximal portion.
And you can go back for it also in front. Eh?
You're going to lock it. Yeah. And you can also polish. So it is a topic of controversy if you use it antigrade or retrograde polishing. I think for very severe lesions, retrograde is potentially better and easier. So you want to get it distal to the lesion, then you polish all the way back. In this case, we did the antigrade polishing, and the patient was very stable. You normally let the vessel breathe for 60 seconds between runs. And you need to have verapamil or calcium channel blockers and nitroglycerin available to use in case of no flow or slow flow. So in this case, his pressure is stable. The patient does not complain of chest pain. We have good rhythm. So we'll maybe do a second run, or maybe the fellow do a second run after that.
And about you go to 80. What was the speed of you're going?
So we are at 80 RPM. We're doing the low
speed.
Yeah, low speed. And we listen for tonal changes. Already, I don't hear the changes now anymore.
So I think you made your way there.
I think we did. There is a bit of change in the mid portion, however.
Yeah. We could go a few more times.
Yeah.
Go in the midsection a bit because we saw this.
In the midsection. Yeah.
Okay, we'll wait a bit and we'll do another run and I maybe go in the mid circumflex. Because we saw a change in the
we did. So we listen for, exactly. So that's really the key. And usually after 1, 2, 3 runs, you should not hear tonal changes anymore if it did a job. This should allow proper stent expansion, also improve the compliance, so facilitate the stent delivery. Oui, est-ce qu'il y a un problème? Just saying.
So do you plan a balloon after that? Or
no, I think we would stent. We're already pre-dilated.
Okay.
Faire un ACT.
Les 3000, c'était il y a 5 minutes.
Okay, so we'll do another run of Diamondback.
Yeah, I'll do one.
Prepare the stent. We'll take a picture to find out the length and the size of the stent.
So I think after that, once it's time to improve that stent, maybe we'll put the 2 wires in the marginal and the LED just to make sure that we have access to the vessels. Yeah.
Plus distal, hein.
We go slowly.
Very slow. So I don't hear tonal changes anymore.
We listen to the sound. Pretty similar.
Me release.
That's very nice.
Mes lunettes
So
sur
you
mon
go a bit further down if you can.
Mes lunettes par-dessus. Et pinch the nose.
And see some extra systoles.
Par-dessus.
Yeah.
Merci.
The wire changed pace also, but I think we're okay.
All right.
So do we need to do another one or we're okay now? And we
I think we're good. I didn't hear any tonal changes.
Okay.
I think we should remove this.
Let's remove it. And
okay. So
Dynaglide.
you want to, so yeah, we can demonstrate that. Glide assist. So we hold 3 seconds. We actually have to think this. There we start. Glide assist.
Glide assist.
Maintenant, ça marche pas.
Is it glide assist? Huh?
It's on, but let me see.
Clique sur le bleu là-bas sur la console. Okay.
Okay, let's just remove it.
Yeah.
So just a second.
Perfect.
I mean, we actually need the glide assist in this situation.
I think it's good.
It's good if it gets stuck.
Attention, attention.
And then we'll get the microcatheter back in. Attends un peu. The wire is moving a bit too much. Maybe we slow down a bit.
Okay, good.
Okay.
Yes.
Copy. All right, so let's bring the Corsair. Just take over. In the meanwhile, maybe we can measure on IVUS the length of the lesion, please.
Geneviève, tu peux nous faire des mesures
Jen?
sur l'IVUS?
Mesure la longueur de la lésion, s'il te plaît, entre le guiding et le point ici. Mets un bookmark.
Ouais, on va essayer de
Tu
voir.
fais
À
un
mettre aussi.
On peut-tu regarder l'IVUS pour la longueur, s'il vous plaît?
I'm not just to save dye because the patient has chronic kidney disease. I am not doing any angiogram yet. I'm just going to change the Viper wire for our run through, and then we'll do an angio after that. I don't suspect any no flow or slow flow because the patient is so stable. The ECG is normal, pressure is normal, so I'm really not worried about complication at this stage.
C'est ça, parce que moi, je peux pas y toucher, là.
Je veux que tu remontes jusqu'au guiding. Fait que mets un bookmark ici et remonte jusqu'au guiding. Tu le vois, là, il est distant.
Dans le run through aussi.
OK.
OK, run through.
Doucement, doucement.
Donc là,
Non, je le vois pas. Non, mais Jen, je veux que tu fasses sur la IVUS,
Sur l'IVUS, ouais.
pas sur le,
je
pas sur le
l'attends pour
QCA.
mesurer, là.
So we also did QCA here, but it's not as useful. We're just going to measure the length of the
longueur de
lesion.
la lésion. Pas grave.
Il est déjà très formé.
C'est un nouveau run through.
Passer la lésion. Là,
Pourquoi?
pas dans le segment distal, ça. Ça, c'est proximal. Proximal. Distal. Bon, c'est bien gros, ça. Ouais, là. Okay,
On va ouvrir le sillon bleu aussi.
Ouais, là. Il remonte là. Jusqu'au tronc commun. Par là. Le tronc commun par là. Ouais, dans ce coin-là. Ouais, dans le guiding, ça fait combien? La longueur.
I mean, a small branch based on, this is good.
Trapping.
Yeah, on va air glide.
Juste le trapper
Non plus.
avec ça.
OK. Ouvre la valve et fais-moi un...
On va mettre longueur.
Fais-moi de la scopie.
Longueur.
Vas-y, avance un peu.
Ah, mets bookmark on peut-être.
Avance un peu.
Ah.
OK.
On
scopie.
aurait 24, 25
Ouvre la
mm, Robert, from normal to normal. 25 mm.
Voilà. Just off scopy. 25 mm. Okay.
Yeah.
We're going to take a
left main
35,
to the
25 or a
okay.
bit longer for
Yeah. Megatron 35 or yeah.
35, 25 or something or longer.
Yeah, or
On peut
long.
aussi avoir une pince, s'il vous plaît.
Yeah, that's good. Okay. So IVUS measured. We see the angiogram. Appears to me it's longer than 25 though. Oh, that's nice.
It looks really good. Yeah. So we still see the
So do you
calcium.
want to put a wire in the LAD now or?
I would put a wire in the LED and I would put a wire in the marginal. You could see the marginal is a bit pinched. So hopefully we don't have to deal with that, but we'll see the flow does look normal in this case. Can we see the atherectomy,
Angio?
please.
Oui, c'est bon.
Yeah.
Pardon?
Okay. And put this as reference.
Oui, c'est bon.
Put this as reference and
So we'll
maybe
go put
show the
stent
neoangiogram.
mid circumflex to the left main, huh?
Yeah.
And use a kiss pot.
So what's the length?
3.528.
3.528. Perfect. Okay, I'm going to have the Xian blue.
Yeah, that's a good question. For the CSI, the same cocktail. It's not the same cocktail.
And I will have another blue towel, please.
But it's a cocktail. What's the name, Robert, of the cocktail for the Viper, for the orbital? It's a different cocktail, as I can say.
Like the Rotaglide, but
yeah.
Okay, an autre blue towel.
Okay.
Blue towel, please.
Okay. So
blue towel.
Et une pince.
Yeah, it's called Viper Slide, 20 cc and 1000 normal saline. So that's the cocktail. Well, the Viper wire is quite easy to manipulate, to handle. I think Robert used it even without a torquer. So
we need a torquer. It's actually easier to maneuver the Viper wire than the Rhoda floppy or stiff Rhoda wire.
You were able to advance it without
it's much easier to maneuver. I think that's one of the advantages with the orbital atherectomy. It is definitely easier to maneuver. And you don't need a question. You can use a torquer if you want, but I did not use a torquer in this case.
I think now the question is to go protect the LAD.
Yeah.
So
I think our plan now is to protect the LAD and marginal.
Yeah, for the marginal, at some point is just not to entrap the wire.
No, so we have a Xian blue. I'll take a second Xian blue. You see here, so I wired the marginal very easily. Yeah, so
very good fingers, Robert, to handle that without a torquer, huh?
Yeah. Please, another Xian blue.
Xian is a great
or Xian régulier.
Là-dedans, t'as la CX.
Yeah.
Ça, c'est la marginale.
Pardon? Okay, I run through. Just going to protect now the LED, and then we'll deploy the stent. And hopefully we have time for a quick post PCI IVUS.
Oh, sure. I think we'll have time.
I'm going to take a second insufflator, deuxième gonflette, 2 ballons 2.5-20 au 15 non compliant, puis un ballon 5.0-15 non compliant. 5.0 et 2.5-15.
There's actually the pot. I don't know how much stent you're going to have in the left main, Robert.
No, but we can always go in the order, you know.
Okay.
Mais peut-être un 5.08.
Yeah, just put that aside.
So I'm preparing already for the kissing 2.5 balloons, just to open the struts. And then the pot, we would use a 5.0 balloon.
Yeah.
And in this case, we're probably going to need to kiss and open the struts, both for the marginal and the LED.
Excellent. Yeah, so the kiss pot is like my standard in bifurcation. It helps for the wire access. It helps to have a better result. But in this case, you have the LED, but you also have the marginal. So you're going to need twice pot, kiss pot.
Peux-tu me 10-40, s'il te plaît?
10-40, s'il vous plaît. And you have to be quite meticulous with the pot, not to go across that side branch and not to, put it in the non-disease or proximal vessel. So we'll see. On a spider, maybe, or
yeah, probably spider. I mean, the little branch. I thought I was in the LED, but even spider.
Yeah, spider. Well, that's great. I think it's going very well. Everything is under control. The pressure is good. The patient's doing very great with that mild sedation. And now we're going to go in the LED. The guiding is committed to the circ. We may push it a bit.
Push a bit on the guide. And
yeah, to push it a bit to go to the LED. Up, you're almost there. Excellent. Up. turn it maybe a bit another side. Sometimes you twist it, you're getting there.
It's prolapsing into the.
Collapsing, I see that. Are you in the LAD on a small branch maybe, or I don't know? Prenez une grande respiration, monsieur.
Sortez l'air. Sortez l'air, monsieur. Ça m'aide pas.
Gardez l'air, gardez l'air.
Non, ça m'aide pas.
Yeah, the guiding is quite committed to this circumstance.
Ouais.
Respirez normalement. You're close.
La courbe.
Yeah.
Change. Donne-nous un.
Excellent.
OK.
Excellent. I like that because
Okay.
you understand that's good to have that curved wire.
Ouais, différent.
Okay. So now you have the wire in the LED, you have a wire in the marginal. Get the good wire for the stent.
All right. So that looks like I'm into the LED.
LED
Just
perfect.
going to push that wire down. It's knuckled. I like that. Okay. Let's bring the stent.
Yeah.
On va se remettre en AP20 vers les pieds.
Okay.
AP20 vers les pieds.
AP20. OK, good. Ivis va être prêt pour tantôt aussi. Ouais, parfait. Je vais juste te dire les autres étapes. Là. Sinon, il faut faire le podcast spot avant, après. Là.
C'est entre nous.
OK.
Okay. So the stent actually went really easily.
So
And now I have time. I can actually, okay, test. Okay, I like that.
I like that for that portion of the disease. Yeah, that's good. We have enough to do a pot.
Do you want to check another view?
This
Or
time
you want to check the Ivis or that's not the Ivis, the spider?
There's some like en trait de
No,
dissection.
the spider.
Yeah, maybe.
Je pense qu'il faut qu'on a plus de distance quitte à.
Je peux revoir l'angio post-PCI? Ouais, OK. Yeah.
C'est ce que je veux dire.
Yeah. Bon, non, reviens
Okay,
en
25?
AP20, ouais, AP20,
AP20.
comme tantôt. Fais le checkmark. Non, fais exactement le roadmap.
Qu'est-ce que tu fais?
Remets-toi en 24.
Alors,
Reviens en 24. Plus de AP. OK, check.
Excuse-moi. Là.
No, it's okay. So roadmap à proximité, then you check mark. And then so with the roadmap, we can actually exactly get the same view that we use to just to overlay everything. So here there is a bit of a dissection distally. I think we're covering it.
Maybe we'll need to two-step.
Everyone need two stents. Yeah, that's the issue. Because there is a bit of a dissection. Right.
Do you prefer to go address the dissection distal and then put the Megatron after?
Do we have a 3532 Megatron? Ideally, I would like to have one stent. I think two stents is going to jail the LED maybe with two layer of stents. Like, I don't want that. So maybe to go a bit longer.
So we try to see if we have a longer Megatron. Do we have a 3.5, 32 or 35?
Yeah, 32.
36?
Huh?
regardez.
Because the other option is to put that Megatron there, finalize, and go put another stand distal if you want, or
Yeah.
channel.
Okay. So you know what? I think I would stand like this and then maybe cover distally.
Yeah.
Gaffe le guiding juste.
Test. Test. Just take a test. Yeah, okay. I would maybe stand like that on.
I think that's good. You will have enough space to do a putt at the end in the left main.
10.
14.
Pas trop gros pour distalement, là, mais 12 maybe.
So we don't cover all the way to the ostium, but which is okay because it's not diseased. We do have enough area for pot, and we can see the LED is okay. Off. I'm just gonna pot a bit with the stent balloon first.
Yeah, we need to pot. So 508 maybe, huh?
Yeah, just a second.
Ce ballon 508 non compliant,
On
s'il
ici
vous plaît.
12. Wait,
What's
wait.
interesting to see that we're all undersized as you could see flow in the LED, yeah?
Ouais.
So that means
14.
really we need to go bigger in the left main.
14.
Montre-moi.
Okay, what do you need?
Just gonna pot with the. I'm gonna go 20. I'm going really high atmosphere with the stent balloon just so that it makes it easier for us to re-engage after. I'm gonna pull on the balloon. The guide should go in.
That's good. That's nice. Okay, parfait. So Robert, I'm giving you the 5 millimeter by
Exactly.
8 millimeter, huh? 5 by 8 balloon.
The balloon doesn't want to move.
I mean,
It's like stuck.
oh, it's a big, yeah, a long balloon. Maybe that's why. Yeah, inflated, deflated.
Because it doesn't, it's stuck in the guide. Show me the guide, please. You see the balloon? It's not moving. Okay, it's moving forward. Okay, it's out.
Better now? Good.
Perfect.
So sometimes just inflating, deflating,
Right,
and the guiding can help you. I was wondering if it was not the wire that were crossed, but
It's possible.
It
But
went down.
that doesn't seem to be that. Sometimes you have no choice but to remove one of the wire if they're crossed, but I think it was just the balloon, the profile.
I think I'm, oh, look at that.
Yeah,
I don't know what happened there, but the balloon is all,
that's what I thought. So sometimes when you have 3 wire, obviously you have to kind of maintain the relationship between each wire. In this case, probably by.
you'll have all our wires in
Oh,
position.
wait. So you pulled.
It looks good.
Good. So that's an interesting.
Actually, I don't think we need to cover more distally.
No,
Maybe not.
It looks
We'll
good.
do with Ibis. We'll see with Ibis.
The flow in the LED is a bit slow. 10-40. Let's just go see
10-40,
what's going on in the LED, just because I wonder if it's me or is the flow slow.
No. But we'll see in this 40. I'm preparing the balloon to pot. Tu peux faire ça. Ok, c'est bon.
Moins de tête. Moins de. On voit trop la
Vas-y.
tête du patient. Comme ça, ouais. Actually, that looks good. Okay. Now I think we should pot. Actually,
Yeah.
I think I'm gonna attempt just to rewire.
je vais pas poter d'abord.
Okay, pot. We're gonna pot
No,
first, and then I'll rewire. We're gonna kiss
Yeah, I would
pot,
favor
and then
pot
Ibis.
because we use a 3.5 in a 5.0 stand left main. And I'm worried that you could go under a strut, with the wire.
Yeah.
So if you
I
could
think
gently pot,
I think my lesson for this case is that initially we really had issues wiring the circumflex, and I think using microcatheters that are angled can help.
yes.
And the second issue is that we had problems delivering balloons or the IVUS initially, and using orbital atherectomy, we were able to change the plaque, probably increase the vessel compliance, revient en AP20 vers les
Ouais,
pieds,
c'est ça.
and basically make the procedure much easier. We never had to, use a guideliner or use additional support. That we're able to deliver of long stents and shockwave, etc., pretty easily. Table en L déplacée, so you have to move it like this. Okay.
Okay, that's good.
Okay. On ici.
Make sure you're
Go,
really,
Davino.
you're really not
Cool.
too far, huh?
No,
12.
this is pretty good. So this is a 5.0 balloon off.
Do you want to use?
Normal.
On a bientôt fini.
12.
You want to use like a stand boost, Robert?
No, I think it's.
You okay?
Let's just rewire and we'll repot
Okay.
at the end.
Do
We'll see with IVUS.
you want to use another wire then?
No, I would use those. I think the flow is okay. Combien la douleur sur 10, monsieur? Combien la douleur sur 10 en ce moment? Dans le dos ou dans la poitrine? Ça a commencé quand? Ça a commencé quand, la douleur? Patient has 5 on 10 chest pain. C'est quand que ça a commencé? Ça fait des minutes, des secondes? 30 secondes. 30 secondes, OK. Est-ce que là, ça va? Ça s'en va, OK.
Okay.
Ouais, c'est le pot.
Patient had transient pain about 10-15 seconds ago, and now
Okay, I'm going to try to rewire. I think
Okay, you have
this
the
is going to
torque
be
there?
easy.
Gaffe lequel tu retires.
Going to remove my wire from the circ.
Same thing. I like to use like a distal wiring so I can move
So
this
right
way.
now I'm not cold inside the stent.
Yeah.
And again, you can see it's pretty, the wire is free.
Okay.
So we have rewired the first wire. I'm going to try a spider. Let's rewire the LED.
Better for the LED. Spider.
Ton guide, il est.
You can have another 10 minutes for that transmission.
Thank
and
you.
if you're not done, we will still record locally.
Okay,
sounds
perfect. Thank you. So we're told we have about 10 minutes, so we'll
Hmm?
continue.
To the LED.
The plan is to do the pot, do the opening of the
Going to
LED,
remove the
do
LED.
another pot and see with IVUS. We should be able to do that within the next 10 minutes.
So you saw like it was very easy for us to rewire the marginal.
Yeah.
I would not reopen the marginal struts around because it's
No.
the Megatron has very big struts and we do risk the to maybe make things worse. There's been some plaque shift, but the flow is okay. The patient doesn't have pain anymore. So at least for the marginal, I would leave it as is. And in the future, if we have to go, the wiring was not a problem, you know. Roadmap à proximité.
Ouais.
Tu fais check mark. Tu fais le
Check
check
mark.
mark first.
Depuis longtemps là.
Tiens,
Depuis longtemps,
ça t'amène exactement.
à l'endroit où tu étais.
Ouais.
That's a nice feature of the Philip room, the roadmap, and then the
Because it's easier we don't need to use dye, you know, for secondary.
Change le wire. Non?
Ouais.
the wire appear a bit
Yeah.
damaged, Robert. Should
Yeah,
we
I think
another wire?
I'll take another Xion black.
Okay, we have a Sion black, please. Sion bleu ou Sion black?
Bleu.
Bleu.
On en a plus.
Or Xion
Jet.
black. Black.
Yeah, I think we'll be able to get there with a little curve on the wire.
We had issues in the first, you know, wiring the LED.
Again, the guiding is committed to the circ, so you may have to pull it a bit
Yeah.
and change the angle a bit if you can. Great. So everything is under control. Robert, you're doing great.
Yep.
Quentin
We hope to
also.
get we hope to get the kissing and the final IVUS in. Would be great.
Kiss putt. And we'll finish by the putt. And then IVUS.
So I like to use the Xion black for rewiring or Pilot 50 just because it has hydrophilic tip. It's better able to navigate the stent strut.
Okay.
Plus sur le guiding. Ouais.
Yeah.
As you keep wiring, I can ask Sophie if there's some question on Slido. Sophie, is there any question? Okay, no question for now. So hopefully
Good.
this demonstration will be useful. That's great. I think you're almost there.
I wonder if I'm behind a strut.
Well, maybe you're,
Test.
and yeah, be careful because you could be in the proximal part of the stent. Exactly.
Yeah.
Try to go a bit more
Want to be
distal,
more
and,
distal, yeah.
and come back. Yeah.
Test. Ça fait quoi?
Ah, dans le dos?
5 ans de fentanyl. On a bientôt fini.
Oui, ça avance bien, monsieur. And that thing, I think you're there.
Yeah, I think that looks better. Test.
The same issue we had initially with the wire there and the LED, but you were
It
able
is
to.
stuck into, you see prolapses.
Yeah. Excellent.
No, but it's not going.
Well, it's not easy because I think
It seems it's in a different branch. Like it looks, because before I also thought I was in the LED, but you see it's not going further. I'm going to change the tip because
in a second curve.
put a big second curve.
Nous, on va prendre la. Regarde. On a plus besoin
Can't
de
reach.
ça.
I'm committed
On a
to the
plus besoin de
circ,
ça.
like
Ça, on en a
Dr.
besoin.
Tanguy mentioned, and
Ça, on a besoin. Puis ça, on n'a plus besoin. Exactement.
put a very big curve, and hopefully it goes through. This is the little branch. This is good. I'm inside the
Circ is
stent.
good. Yep, there. Slowly. Because it keeps on doing a prolapse, but I think
It's
you're
two
there.
prolapse, but
Good.
I don't know. I feel it's
Well, you
not
have
free.
another review because maybe it's a strut. Maybe you're.
maybe
The circ is perfect, and then you just come back and the LED. Yeah,
this is
that's a
the
small
little
branch.
branch. I want to be a bit more proximal. Always hard to. I did not expect so much challenge rewiring.
No, but I think it's good. I think. T'es allé en 15-25, veux-tu prendre une autre vue? T'as l'air bien dans cette vue-là, mais OK.
Wait, it's prolapse. Like the wire is not free. It's like
Oui, là,
okay, 10-40. Let's
ouais,
just see what's
40
going
ou
on.
15-25, ça va te montrer l'IVA proximal.
C'est ton type qui t'empêche.
So
Ouais.
sometimes it's just a matter of view. There's probably a small branch
trying
there we
to
don't
pull
appreciate
back.
well in this view. So I'm
Faudrait
suggesting to change
Il a eu
view.
dans la cercle, tu prends celui de la cercle.
And there we go. 10
Ouais.
Il a l'air d'avoir.
Pas 10-40, Robert, c'est toi qui le fais?
Oui.
10-40.
C'est lui qui. Ouais. Moi, je fais des suggestions, il les prend ou il les prend pas. C'est pas grave. Je pense dans une petite branche, mais on va voir.
Déplace la table pour mettre le roadmap central. That looks good.
I think you're good.
Yeah.
Yeah, you see, changing views may help a lot. You're there.
It does.
Excellent.
So I like this. This is knuckle. Okay. Let's get the 2.5 balloons and
On va retourner dans la vue qu'on était tantôt.
maybe we can kiss
Ouais,
first.
je pense que Spider va y aller.
Pot and Ibis. Oh.
Kiss
2 ballons 2.5.
and then
voilà.
pot
Ouais,
and then
c'est longtemps.
Ibis. 15, 12. 15, c'est correct.
Ah, il va pas. Bon.
We're going to go first in the LED because that's the
Yeah.
tough to wire, and then we'll go in the circ.
Sometimes
Okay.
to save a step, I bring the two balloons and inflate, but let's go the LED first. It may be the most difficult because of the stent and the way you cross with the wire. We start with 2.5 and we'll see. I use a thumb of rule about for the proximal size, 2.5,
Point
2.5
fixe, s'il te plaît, Quentin. Point fixe.
is 2/3 of 5, so that's okay, let's go.
Juste préparer le ballon.
Montre-moi la distalité. C'est-
Lui, là.
Voilà, on s'en sort.
OK.
Wait, just a sec. AP20, j'aime pas le spider. Et on voit il y a
AP20.
beaucoup de radiation, puis si on voit rien là. Hein. Toujours AP20 pour se placer.
Bon. L'autre ballon, c'est l'autre
Le
ballon?
deuxième point 5, il est où?
Il va nous l'amener. Il va nous l'amener. Hein?
Ouais.
Ouais.
Oui, on va avoir deux ballons 2.5.
You see, so we keep going in Spider, but you see in this view, it's so much easier and we actually get less overlap. So we're inside. So let's bring the other
The other balloon.
balloon.
Let's do a clean up here. OK. Ouais, c'est bon. Prends-le, puis moi, je vais m'occuper de gonfler. Il est rapide, il est rapide. Vas-y, négatif.
C'était aussi, les amis.
On va le faire à la fin. So my eyesight is getting very bad, you know. I can't put the balloon. Okay. Finally got the balloon.
You're good. You're good.
It's getting difficult. I gotta say, I wonder if I'm developing radiation cataracts.
No. Too young. Okay, excellent. So we'll do the kissing, then the final pot, do the IVUS.
There's a wire that was pulled a bit.
Are you okay?
Yeah, it's good. We have a lot of wires, so
That's good. You
yeah, it's
pull
good
back the
here.
LED one maybe a bit,
Yeah,
or
pull back the LED.
you see the proximal LED hasn't been touched by balloon. It's just to open the strut.
Just
I think
open the
very well.
strut, so it's also a 2.5 balloon. So
X pour tirer un tout petit peu.
ouais, comme ça.
I think that's good there.
Okay, let's go.
Go both of you at the same time.
Good
10
low atmosphere. Just trying to open the struts. 8.8,
Eight.
non-compliant balloon. Looks great. 1, 2, 3, off.
At
Okay.
least you open the strut. You could go bigger if you want. You could use a trio in the LED and a 2.5.
Yeah,
For now, I think we'll see.
We're just gonna remove both balloons.
Yeah. So you're gonna have the 5.0 that we had? Do the pot for the IVUS?
Yeah.
Okay, 5.0 by 8 that we had.
Sortir le guide dans la marginale ou pas?
Ouais, je pense.
Guide de trop.
Ouais. On va enlever le guide en marginal. I think it's the one. Yeah, this one. And remove the marginal wire.
Good.
And then we're just gonna go pot on the
Pot and then the
circumflex
IVUS.
wire and then IVUS.
Then we prepare the IVUS. The IVUS is ready, waiting.
And we can use a stent boost here to pot.
Absolutely.
Ballon 5-0.
Le 5.0, il est où? Le ballon 5.0.
5-0, s'il vous plaît, 5-0-8.
Merci.
Suivez-moi.
Yeah, we'll have to prepare that 5.0. It's big. Yeah, vas-y, puis il va falloir que tu le dégonfles.
Ouais, bon, it's okay.
It's a bit big.
I think it's
You have
gonna
to
go.
prepare it.
It should go.
Okay. I'll put it negative. Hopefully it's going to help.
Such a big vessel, I think we're not gonna have
big.
issues. We just have in French.
Yeah, exactly.
Yeah, the patient has been very, very good. You know, last week he could not handle 5 minutes, and with
Very-
now almost an hour 40-minute
It's
procedure
better than last week for sure.
for sure. Yeah.
Ça rentre difficilement.
C'est bon, c'est vrai. Well, IVUS is ready.
Hopefully, we get nice images on the IVUS, and
Yeah.
we're happy.
Okay.
I always like to see the
distal
your
wire.
Pull back your wire. Double. Okay.
Yeah, good.
Because it's too distal, it's gonna perf.
No, I don't like the meat either. Okay, you're far now. You're too far. Come back
Pull
a bit,
back a bit.
Quentin.
Stand boost.
On va être au milieu.
Non, vas-y, plus de recul.
I think that's better.
Et quand
Make
t'es
sure
proche
we're
de
really
bête,
proximal, not to have to reopen the strut and the LED.
Push a bit. You're two out of this.
Yeah, now he's 2 out. Yeah.
Okay, here, stent boost, ciné. Un peu.
Diego, c'est bon?
C'est bon. Vas-y. Push in.
Oh, you see the stent, huh?
Yeah, we see. Push.
Have to go a bit further down, I think. It helps us a lot, the stent boost. Yeah, let's
Okay,
go there. That's actually where we were before. You see the size of the
yeah, it's definitely, we
That's
definitely
perfect.
pot. And now maybe we take it, I don't have the chart anymore, but I'll take it to 16
Oh, that's perfect.
off. Ouais, ça fait mal, c'est normal.
Yeah, 5.12, 16.
So it's pretty good. It was a bit above 5 on
Yeah,
IVIS.
that's good.
We can
Exactly.
remove this. La douleur va partir, mon cher monsieur.
You prepare the IVIS now.
IVIS, and then I would only do one view if the IVIS is good.
Oh, yeah.
Minimize the dye. All right.
Oh, my God. Okay, that's good. Guys. Good. This.
Le guide qui s'en va.
Ouvre la valve.
Okay.
All right, on va
So
prendre
that's the
ça.
IVIS. We'll advance it, go slowly, and I'll advance this also.
Tes guides, ils sont tous un peu aux fraises, là.
Okay, push the guy.
Is that the wire from?
Yeah, yes, sir. It's okay.
Okay,
Push
good.
that. Okay.
Like I say, better be lucky and good than bad lucky and not good. That's good. So let's go straight. We'll go through all the stent, eh?
Yeah. Yeah, we see it. We're going to image the whole stent.
J'attends un peu parce qu'il est pas.